Hello, hi everybody. It's Dr. Kurt Lowry here at the university and director for the Center for Distance Health. And we're very honored to have Mr. Scott Simmons here. And I know Scott real well from American Telemedicine Association. We're on the institutional commission, and Scott's a really good guy. He's the director of telemedicine at the University of Miami Miller School of Medicine. And we had discussions in the past about NASA. He worked in NASA before, and I'm very much almost a worshiper, fan of NASA. I always have been since I remember as a child waking up at 1 or 2 o'clock in the morning when they landed on the moon the first time and watching it on the TV and how fascinating that was. You could actually see the first astronauts as they stepped down on the moon. So NASA has really done a lot of great things for America over the years, and hopefully we'll still, now with the commercialization of space, we'll still be able to continue to move forward. And he helped develop NASA's first space-certified telemedicine system, and he was a former board member of the American Telemedicine Association and is currently, like we said, on the Institutional Commission. He's a member of the editorial board of the Telemedicine and eHealth Journal, and research interests include medical data and device interoperability, internet protocol, video conferencing, wireless networking, information and communications security, and consumer health care. And today he's presenting the value proposition of health care. So, and that's really now, I think we're very much involved in improving the quality of health care in the state of Arkansas, but also how can we do it more efficiently. And with the state so engaged now in reducing healthcare expenditures through combined efforts of Blue Cross Blue Shield, Medicaid, Medicare, United Health, and pretty much all the groups working in collaboration as though they were a racket, racketeering sort of. But is it just being a webinar, or is it?
It's just a webinar. I'm just a webinar. Well, thank you very much, Kurt. And I'm doing 2 other presentations today, and actually it's interesting. The last one I'm doing is on our program. So if you're on the webinar, you're not going to hear that. So I'll give a little bit of background on what we're doing at University of Miami. We are a private university. We're the oldest medical school in the state of Florida, the oldest allopathic medical school in the state of Florida. So we're kind of the original group. The fee-for-service reimbursement for telehealth in the state of Florida is pretty much non-existent. There's one exception, which is the Children's Medical Services Program, which is through the Florida Department of Health, which is a health safety net program for children with special health care needs. So aside from the camera's on you, Scott. All right. Just tell me. I don't have a mark.
Yeah, I know.
Where's my mark?
We can't. Oh, there.
Okay. So I need to be more over this way. All right. I'm hiding behind the.
All right.
Pay no attention to the man behind the monitor. So what we've had to do is, in the absence of fee-for-service reimbursement, is find ways to kind of grow and build and develop our telehealth program. So we're a little bit of a different animal than a lot of programs, is that we serve very much an urban area, and Medicare does not pay for telemedicine visits in the urban area, which is interesting because there are so many Medicare beneficiaries in Miami-Dade, Broward, and Palm Beach counties, which is the area we serve. So we've had to be very, think like a business and be very focused on contracted services, which is one of the ways we've done this, and really how we create value through telehealth. And one of the things that wasn't part of this brief bio introduction is I am a former VP and CTO of a failed telemedicine startup. So when I left one of these devices that I developed when I was at NASA, we got a patent on. NASA waived its commercialization and patent rights, and the CEO of the contractor I worked for and I boldly went forward to start up a company right when the dot-coms were busting. But you talk about the experience, you hear about this, but trying to be an entrepreneur, how much that experience is worth, and I would agree with that. So in speaking to venture capitalists and speaking to potential customers and investors, this whole idea of value proposition is a real key terminology. I don't know how many people have heard this kind of term value proposition, so a few. So I'm going to get into value proposition a little bit. Now, what's value, right? How do we look at value? It is forwarding now. Okay. I'll try to keep an eye on where things are. Well, a lot of people think of value as the cheapest thing, but really what value is, it's a trade-off. It's some trade-off between cost, and then I have it mathematically described here as some sum of different things, but it could be cost and quality, could be cost and sexiness, let's say, of a product. So you're thinking like, so let's say I'm a big Apple user, Apple fan. I think it's cost and quality, but the industrial design, whatever those X factors are for you, it's really about a trade-off. So in other words, maybe a better way to put it is, what's the bang for the buck, right? Is really what value is. So it's always a trade-off between two things. So it could be in healthcare, it could be quality, could be convenience, could be a variety of different things. But that's really what we're talking about when we talk about value. Now, if we look at value proposition as a business term, and I'm going to show a business directory definition, but I thought this was pretty good. It's really a combination of goods and services that are provided in exchange for payment, which I think is lumping goods and services together. I think is really appropriate to what we're going to be talking about today, and it's always compared to an alternative. So if I'm looking at what a value proposition is, if the value proposition is to the buyer or the customer, right? And we'll talk about who the different customers are in a minute. But I'm evaluating what that company or that institution is proposing to me, and I'm comparing it to something else. And I think that's the other important part of this. Now, I don't expect you to be able to read this, but this is the book. This is actually the guy that wrote the book on value proposition. He actually started up a company that's looking at profitable value. And I don't expect you to read this, but I'll read something out of this, and I commend the book to you. So basically what he's saying is, if customers find that scenario experiences, including the price, to be superior to the alternatives, even if it includes trade-offs versus those alternatives, they will give the enterprise their revenues. And I think that's a real powerful thing. And it's really a kind of a misunderstood concept, because what people look at value proposition is they've equated it to a marketing statement or a elevator pitch or a product positioning statement, which is not really what it's about. It's really about your sum total of your goods and services, and your whole existence is for delivering value to your customers at a way that you can be profitable, is really what the whole thing's about. And I really thought his approach to this was really good. And definitely don't read this, because I'm breaking this down. And so as a simplistic example of what is meant by value proposition, he looks at automated teller machines, or ATMs. And I think this is a really good one to start with, and we'll come back to it in a minute. So let's look at Lanning's ATM example. So he's got kind of a 6-point analysis here, which I thought was really good. So what's the proposition? Well, one is you get cash as accurately as you would from a human teller, right? That's probably, I would say, the most significant. Excuse me. You save a significant amount of time. You reduce disruption in people's lives by doing it this way. I'm sorry, my transitions are taking a while. Decrease the number of incidents of being out of cash because you're not subject to when the bank hours are, right, versus going to a teller. And we know bankers' hours, surprisingly, are perhaps even less convenient than physicians' hours. We can debate whether who's got the better hours. But you do incur a slightly higher chance of, what? OB is different. No, I know, but a lot of specialties, especially outpatient stuff, yeah, and definitely in primary care and internal medicine. But you do incur a slightly higher chance of getting mugged. And you'll see the parallels to telehealth. I'll get there. And then the other negative, I guess, is you're paying some transaction charge related to that ATM service. So if you look at the total value proposition, the bottom line, is that there's one equal experience, so that there's an equivalence in the accuracy of getting the cash. 3 of those are superior experiences, and they're really geared towards time and convenience and hassle factor. And there's 2 inferior ones. So there's a slightly higher security risk. You're going to get mugged more likely outside, or at least it's a perceived risk to a customer. So it's a superior value to the customer. And I think this is the way we need to, I'm suggesting this is one way we look at how we sell our telehealth services and programs to different customers. And so that's what we're going to get into today. So we're going to look at telehealth through the framework of value proposition, as answering 3 fundamental questions. So first one is, where is the value in telehealth? Or really another way to look at what are the benefits in telehealth, or benefits of telehealth, I should say. How does it compare to the alternative? And we'll talk about what the alternative is right now. And then the third one is, how should we price it? Right? What's the pricing model? So we look at all 3 of those things. So let's start with the first one. Where's the value in telehealth? It really all depends. And it's funny because people don't like that answer. I get that question all the time. We'll get a prospective client that comes in and says, well, how much is it going to, or I want to start up a new telehealth service, or we would like to contract with you for telemedicine service. How much is that going to cost me? I said, well, it all depends. What is it? What is the clinical service you need? What is the bandwidth you have? Do you have a capital equipment budget? What exactly clinically are you trying to do? It really depends on a lot of different things. But in this case, it really depends on who the customer is. And this is really interesting, and part of this whole healthcare reform debate, and Dr. Lowry and I are in complete agreement on this, is that we've got, this third-party payer system really complicates who the customer is. So we talk about consumer-focused healthcare. If we have this abstracted payment system, there's a lot of perverse incentives and disincentives built into that. So who is the customer of the telehealth services? Is it the health system? Is it clinics or physician practices? Is it the employer, since a lot of our healthcare insurance is provided through employers? Is it the payer themselves? Is it the patient? I don't expect you to read this. And I think I brought 5 copies. I don't know if I'm violating copyright, but I'm one of the authors. So we got together with one of our health economists at the University of Miami and one of his colleagues who's working on her PhD, and Dr. Burdick, who's my dean, and I, to look at economic evaluation in telehealth. And working with, I've discovered in working with economists that if I hadn't gone into engineering, I probably would have gone into economics, because very similar mindsets in terms of practical, systematic approaches to look at things. The point here is that what we did is we looked at kind of common outcomes in telehealth from different perspectives, from client, provider, and other stakeholder perspectives. I did bring 5 copies. I don't know if you guys are broad institutional members in ATA. So it's available online. We actually won, this is not to brag, but to say that we think there's something that we won the paper of the year with this paper a couple of years ago, because, and it's really mostly, we kind of asked the questions of the health economists, and I'll readily admit that they did most of the analysis. So, but this is kind of all the things that you present all the time about avoided hospitalizations, readmissions, travel reductions, all these other things. And we'll get to these things from different consumer perspectives. But that's just kind of a table that we might want to start with. So I'll look at 2 different customers. So one is patients, and then the other being a university health system, because that's our parallel, I guess. Number 1 is access. Now this is access in the islands, but it could be access in rural Arkansas. right? So that's the big, I think that's the big benefit to the patients. They get access to a specialist when either faster or at all that they weren't getting before. Convenience. It's interesting. So I've worked in two different major telemedicine programs. One was rural at East Carolina University, and now one being urban at University of Miami. I would tell you that I would much rather make the 110-mile drive from the Outer Banks to Greenville than I would making a 40-mile drive from Palm Beach, or 50-mile drive from Palm Beach down to Miami at rush hour 995. And it's real interesting when you look at convenience. It's not just the driving distance. Is that a colleague of mine at University of North Carolina, Chapel Hill, had a pediatric telerehabilitation program set up. And one of the things he did was he talked about the real last mile problem in healthcare. It's not, we think last mile, we think of the telecommunications line. What he was saying, it's the academic medical center is the real last mile problem. So what he did is he took a couple healthy graduate students or postdocs, whatever they were, that were working for him, and who knew where they were going, had them park in patient parking, and time how long it took them to get from the parking lot to the clinic. Now these are healthy graduate students in their early 20s, mid 20s, knew where they were going, and it was like 20 or 30 minutes. Now his patient population, pediatric rehab, are moms and or dads with disabled kids that are trying to get to rehab. So that you add that on top of that, and then you throw in I know our medical center, this is my first time I've been at your medical center, is a very difficult place to navigate, I think intentionally so patients don't escape. But that's a real hassle factor. It's not just the drive time. It's that once you get to the system, finding your way to the right clinic. So I think convenience is another, whoop, I went the wrong way. And quality. And quality in terms of getting access to a specialist, and a lot of what you're doing, maternal and fetal medicine specialists, with us, other specialists, you get access to that specialist earlier, you're managed a hell of a lot better, if I may say that on the broadcast. And that's been borne out in different studies. And I know we did one in dermatology where we looked at the need for a patient to go back and see a dermatologist after they'd seen a teledermatology visit. It was only in like 15% of the cases they needed to. That the dermatologist's opinion with a primary care provider managing the recommendations from the dermatologist, they never had to be seen for that condition again. So there's a lot of power in that. So I think that's where the quality comes in. And it also all depends on what you're talking about when you're talking about telehealth. If you're looking at remote monitoring for the big chronic diseases, CHF and hypertension, COPD, and all the evidence that's building there is that because we're doing this remote monitoring, that we detect events kind of when they're subclinical. So we're eliminating a lot of emergency department visits and rehospitalizations, because we're nipping things in the bud rather than that follow-up Q6 month office visit that you have scheduled for someone. You're nailing something before it becomes clinical or clinically significant. So I think that's a quality thing in a variety of different parts of telehealth. Now, what about I'm saying a university health system, because that's what I know the best, and that's the audience here. But this could be a private hospital system. This could be, excuse me, it could be Hospital Corporation of America, or really any big hospital system. I think one is revenue enhancement. Now we focus on contracts, but the other is the upstreaming of referrals and procedures. Now, unfortunately, there's not. At least we haven't found a really good way to. This is a hypothesis for us, that we really haven't had a good way to track this comprehensively through our system. How many telemedicine consults actually result in expensive procedures or referrals or hospitalizations? But another big thing, and I'm glad that Dr. Lowry mentioned this on the up front, if we talk about being able to squeeze efficiency use a very limited and valuable resource more efficiency, that we can avoid costs and be more efficient. So we look at reducing travel. I'd imagine that you have physicians that travel out to outlying clinics. I know we do. And they're
Yeah, there are not in our department we use this.
Right.
But most of the pediatrics has a huge travel department.
Mm-hmm. So that's one. The idea of load balancing of clinical capacity, that I know we have specialists throughout our health system. A particular specialist or even a pediatrician at one of our clinics may not have a busy day, that we can make them busy by giving them some telehealth workload. And there's a classic an organizational behavior and management issue that happens, or kind of organizational psychology issue, when you have, and this documented first really in the space program and in Arctic expeditions and that, is that when you have a physical separation between two parties that are within the same family system, the organizational family, conflict arises because there's a breakdown in communications. It happened in the Russian space program where the cosmonauts shut down the radios for a couple days because they didn't think that their Russian mission control was understanding the problems they were going through. We've had it happen at NASA when we were training in Russia. It happens in our health system where we've got a satellite of our cancer center and some of our other centers that you're not physically there every day as part of the mothership, that sometimes miscommunications get amplified across that. So there is and this has been documented in the literature in terms of having access to continuing education and other services by video conferencing back to the master organization or the parent organization has resulted in higher job satisfaction and better retention of employees. So I think that's another benefit to the health system. And I'll say that I apologize, I had to convert from Keynote to PowerPoint, so some of the indenting and stuff is off. But we also see it as a competitive advantage, both in terms of improving access, making it more convenient for patients, being able to virtually co-locate specialists in settings where they aren't existing. So instead of, so whether that's a primary care setting, we can virtually co-locate a specialist. And this term co-location comes out of the mental health community, where the whole idea came of putting a psychiatrist or a mental health provider in a primary care clinic. Patient sits in the waiting room just like they're seeing their primary care physician, but they go in the side door and see the psychologist or psychiatrist without the stigma associated in the small town of, oh, you're seeing a shrink, you must be crazy kind of thing. And that's kind of how that started. And the idea to build collaborative care teams. But there's also community outreach and kind of branding benefit too in terms of building our brand out, extending our university education, and something I know near and dear to your heart as well is a conduit for translational research, for getting the latest evidence out into clinical practice across a wide variety of systems. And I know that's something that's happening. I know that Dr. Lowry is one of the things you're pushing right now. Excuse me. So how does it compare to the alternative? Well, we first say, well, what is the alternative? And it's today's health system is the alternative, right? So I think this is the best movie depiction of an academic medical center. It's kind of the Death Star, and I think we're all old enough that we recognize Star Wars. And I guess in a way we go there to die in some cases, but that's not what I meant. I meant it's a kind of a monolithic tractor beam. Everybody gets pulled into this massive planet of a space station where everything happens. Big, complex. You come to us when it's convenient for us, kind of thing. And I think that's one of the aspects of I think this is the level of customer service we get a lot in medicine too, is the DMV. And I couldn't think of a better depiction of a bad example of customer service. And I gave a talk at that was a weird transition. ATA in Anchorage, Alaska, and focused just on this part, on using telehealth to improve customer service. My wife is in advertising and marketing, and she had registered for this book on Amazon, and I found it interesting, so I was leafing through it before I wrapped it and gave it to her. And there was a section, and really Selling the Invisible is all about how you market services instead of products, because a lot of the marketing is really about products, but to market services, and there was a chapter on professional services, so medicine, law, accounting, and that. And what was really interesting was the guy made this point, and I was a little taken aback by it for a second, but then it made sense, is that the average customer of your service assumes your expertise because you have the degree, you have the credential, right? That I'm a physician, I'm boarded in these things, I work for this hospital, but we seem to try to compete based on our expertise. Well, your customers don't really care. They assume you have the expertise. But where we're really competing is that we're competing on customer service, is really because I can't judge whether if I'm just an average patient that doesn't have any really medical background, I can't judge whether this physician is better than this one. And there's so little difference. I can't clinically judge that, but what I can judge is if they're a jerk. I can judge if they're late.
I think you might fit in this flight attendants, believe that their safety features of the aircraft, but consumers believe their service items.
Absolutely.
Healthcare is exactly like that.
Absolutely. Now, the interesting thing about about telehealth, and I had this epiphany recently in talking to Joe Peterson, who is the CEO of Specialists on Call, which is a big private telemedicine company. That he says what they've had to fire several neurologists that they've had in their national rotation because of lousy customer service. And he said what's interesting is that telemedicine exposes all your flaws, because if you have a physician that's a jerk, that what ends up happening is the assistant that day says, well, Dr. Lowry's having a bad day. Not that I'm saying you're a jerk, Dr. Lowry, but he's having a bad day, or this or that. There's a whole group of people, but it's just you and the physician when you're in telemedicine. So there's this whole kind of rethinking of how we provide customer service in bedside manner. Obviously, this is a big one in terms of the driving that we have to do. This is my son a couple years ago. Pediatric care involves not just the kids, right, but involves the parents too, right? So this is not my wife, but it's probably a good depiction of asking, I need to take off. You know, she works at kind of in a busy advertising group. I need to take off to take my son to go do a well check or something like that, right? And then driving, spending all this time, you know, it's horribly inefficient for the patient. Now, I think where you see the interesting thing is where you see where the payer actually pays for the travel expenses, then you see that's where you see a big acceptance. You see less of it where it's the patient, because the health system doesn't really care if it's the patient pays the travel expenses, right? Because it's not coming out of that premium. It's the patient's own expense that they're bearing. And office hours too, another thing. So we're so used to 24/7, 365 drive-through, available on the internet service, but aside from hospitalizations and certain specialties that are 24/7, it's fairly inconvenient. We have two working parent families that are working during the normal physician's office hours, or the kids are in schools during the normal physician's office hours, and that's when weekends and evenings are probably the best for many of us. So that's another factor. So that's a bit about the current health system, or the alternative. Now, how should it be priced, or what's it worth? And this kind of comes down to it all depends on your perspective too. But first I want to go back to the ATM example and how I think it's parallel in telehealth if we're looking at selling the value proposition. So remember, the first one is, do they get cash as accurately as they do for a human teller? For telehealth, I'd say probably. I'd say they're substantially equivalent, and if we're not making that case, we probably need to make a better case, because I think that's one of the most important arguments in it. I think it'll fix, and Kurt, I think we had this conversation in ATA. I think that fixes a lot of the problems with reimbursement. If we say, and this fear of internet prescribing bills and things like that, if you say that the telehealth visit is substantially equivalent to the in-person visit, then it's just a visit, and then it's not special. It's not we have to treat telehealth separately from medicine. It's just medicine, or it's just health. So can we say that? I think probably. If we look at the second one, can we save a significant amount of time? Definitely. For the third one's related, reduce disruption in their lives, yes, again. This is really about access, I think. So reduce the number of, I wouldn't say incidents of being out of cash, or having availability to a physician or having availability to a specialist, I think is the parallel here between the ATM and telemedicine. So I think yes. You see where I'm going with this. This one is very parallel to cybersecurity and HIPAA in that. So I would say maybe, because I think paper-based records and interpersonal overhearing of interpersonal communications are less secure than most of the digital stuff, but this is about perception. Right?
That's the problem.
Yeah, absolutely. So I'd say maybe. Now, so what it really comes down to is this number 6 is where is this, or what's this? And I think that's where the nugget is in telehealth, and how we need to rethink about payment on this. What's the transaction charge or the convenience fee? I think that's the opportunity for revenue, honestly, especially if we're going to do consumer-oriented stuff. So what is that? Now, we're looking at for the patient, what is the fee, or what's the convenience charge? It's a big range. And I say it's between $25 an encounter and $1,800 a year. And I'll give you $25 an encounter is there was a great willingness to pay for telemedicine visits and dermatology study that was done at, even though it was at Harvard, I'd still say it was a good study. And the median willingness to pay to get access to a dermatologist faster by telemedicine was $25. And the range was pretty big, because it was like $16 to $100, I think was the range, or $150. But the
That's the same amount of money that patients that sit help change doctors. They can save.
Right. Interesting. Interesting. And the $1,800 a year is the typical annual payment to a concierge medical practice. It's anywhere between $1,000 and $5,000 a year, but I think that the national average is about $1,800, and that's what people are paying for. People are paying for access to their physician when they want it, when they're talking about concierge medicine, and maybe some other things. So maybe they like the lobby better, or the place is better appointed, or whatever. But I think that's the range. I'm not saying what the answer is, but I think that's the range there. And it's good to start with the range. But there is evidence that people are willing to pay for convenience, right? Now, for other customers, it really depends. And I know you don't like that answer, but I'll tell you what it depends on. So really comes down to what are their points of pain or points of friction, or what their problems are that they're having, the issues they're having with their current system of doing things. And it also comes down to what they're paying now for the alternative. And I can use two examples, and I'm not going to give you the numbers because I'm not going to open the kimono that much of our business operations where we are. But the two ends of the spectrum here. So teleneurology. I know the model that Specialist on Call is set up, and I can say this without violating any confidentiality, is they have a model based on the number of hospital beds. There's an annual fee paid out. I don't know if it's paid out 1/12 of it a month, but there's an annual fee. There's no reimbursement involved in this at all. It's a service contract basically. And the argument that's made is for roughly what you would pay for a neurologist to cover your ED. If you could get one, you get the neurologist. You get to have patients who are suspected of stroke hit your ED. You can, if they're eligible for TPA, you can push TPA. You can pay for the hospitalization. And then if the patient requires some more advanced intervention neurology, like mechanical clot extraction or something like that, we'll help you find a place that you can transport the patient. But there's actually that's kind of the value proposition for them. For us, for one of our customers we have now is we've had going on 3 years now a contract with Royal Caribbean Cruise Lines for teledermatology. So any given day there's about 36,000 employees at sea in Royal Caribbean's fleet around the world. All of their ships have emergency medicine trained physicians and nurses on the ships, but they have issues with dermatology from time to time and access to dermatologists at ports. There's a different, they can handle a lot of the, if you're having a suspected MI or stroke or some traumatic problem, they can handle that stuff, but there's some of this derm stuff that gets kind of complex, and they were really having access issues. So they're contracting with us, and we're doing the same thing. We're doing this annual fee. So their point of pain is they couldn't get access to dermatologists, and it's their employees, and it's a valuable and expensive resource to replace if they have to evacuate someone at a next port and replace them with another employee, right? So that's what I'm saying is that you kind of have to look at what their friction points are and then what are they paying for the alternative. So in the case of, if you can say, well, you're going to pay the same or maybe a little more, a little less than you pay for this specialist, we'll provide this service for that, or right now is this point of pain that they just don't have the access to what they need. So that's another way to sell it. And I know some of you are saying, well, this is kind of touchy-feely, and I'd agree to a certain extent, but a lot of purchasing decisions are emotional decisions, right? So I think you have to be able to, if you're going to have an elevator pitch, if you will, have a real succinct statement of why someone should sign up for your service or why someone should pay you for the service, I think you need to be able to do that. So
Scott, this is all based on the current fee for service. Once we move away from that model, it's all destroyed. Then it's about does the service reduce production costs? That's the problem. Which is a totally different way.
mm-hmm.
And I think in this model, it can decrease production costs, assuming that specialists do anything, which I believe to do. Then having that knowledge available and writing algorithms that manage the system in this discipline will decrease production costs.
Mm-hmm.
It has to.
Absolutely.
So I think intellectually we're working, since we're involved, we talk more about it. The state's involved aggressively in wholesale, starting in 4 areas, but the idea is moving wholesale. All Blues, Medicaid, Medicare, all working together to do bundled care payments in areas. The idea ultimately to have sort of even network kind of payments.
Mm-hmm.
That may be years down the road, but at least bundled care payments, which then means you want to reduce production costs. You want to make diagnosis more rapidly, efficiently, and
well, it's about productivity then. It's productivity enhancement then. So the more productive you can be, in other words, the more patients you can serve with the same number of physicians or fewer, the more efficient you are.
Yeah,
well,
right now they want you to use this to help, in a way, drive up people in their beds.
Mm-hmm.
The fee model right now, fee for service, is about how can we keep people in our beds, fill our beds, sicker patients, and there's still going to be some of that going on, but it's going to be more about how can I diagnose and treat them, get them the hell out of the hospital as fast as possible.
Right.
Which is really different.
Absolutely. Absolutely. So if you want numbers, this is a way to get at them. Now, I'm referring back to this paper, and one of the things that we got into, and this is going to be an important part of all this evaluation we're doing on a go-forward basis, is is to think like an economist and look at overall impact to systems of different levels. And in this case, it might be the state of Arkansas, it might be the United States. It's part of this, really, the CMS innovations kind of philosophy in thinking like an economist. So the idea is all these things that I talked about qualitatively, you can quantify. So the economist perspective is, okay, money is money, time is money, and everything else is money, right? So basically there are conversion factors that you can monetize just about anything. Now, this is where it gets complex. So I won't, like I said, this is another thing. I would refer you back to the paper because we won't go through this, but to look at these different outcome measures that I showed in the first table and then talk about ways that you can monetize these. So a big part of it is quality-adjusted life years. That's a way to get things like reduced length of stay, improved clinical outcomes. It's really outcomes focused, but in terms of dollars. And these are some more, so these are more from the provider perspective and then from other stakeholders' perspective. So this is like the economist tends to look at this really, really high level. But I think it's a good framework for going through and making these kind of larger scale analyses that then you can monetize, or you can make a fiscal analysis of a value proposition or ROI. But some assembly is required. There's a lot of work that has to go into this and some assumptions that make for you to do this, but I think all the tools are there to do that. So just in closing, I invite you to think about your telehealth services in terms of the framework of what your value proposition is. And I really think that one of the challenges we have is that telehealth is a change agent or a catalyst. And so a lot of the problems that we deal with in putting together telehealth programs really aren't necessarily telehealth issues, they're systemic issues. And I think it brings them to the fore. So I've seen this happen before where we've implemented a telehealth service or program and uncovered systems and processes that were broken, but that we uncovered because we were bringing a bunch of people together from different organizations or within the same organization. And so I'll just close with that. So the challenge for all of us is that we're this change agent and we're fighting a kind of an entrenched system. So I'm a Bowie fan, so when we think about change, it's some of my favorite quotes. But the alternative, I would turn the alternative optimism about change into Charles Barkley's quote that sometimes the light at the end of the tunnel is a train. So thank you for your time today. I hope this was helpful to you all. I hope everybody on the webcast could hear me, and I can take. I think we've got about 15 minutes for Q&A or discussion. Okay. Fee for service? Are there contracts fee for service? There are some. It's usually the ones that we have are usually. I think the question is, so I think it's, are there encounter-based contracts? I think is probably what the question is. Yes. So we have some of our.
It's mostly in acute systems where there's a sparsity of resources to provide those acute interventions. Stroke is the perfect example. I guess you could argue cruise ships might be like that.
Well, it's interesting because so the one cruise ship contract we have is a flat annual rate. We bill 1/12. We invoice 1/12 of that per month. The other one we just signed is a fee for service. It's volume based. So the first one is all you can eat, where they're paying a flat rate for the service, and the other one is they want to manage it through their third party administrator but we pre-negotiated what that rate is. So we also have a store and forward dermatology contract with Indian Health Service. It's the same thing that we determined a rate that's based on the national Medicare rates, but instead of saying, well, whether it's going to be a level 2 or level 3, it's probably a 2.5. So we figured the national average, and they agreed to that. But it is an encounter-based contract.
They negotiate